Good morning, everybody. Happy Thursday. Thank you for being here. It is my absolute privilege this morning to introduce our Grand Round speaker, Dr. Borrero. I just wanted to share a few words. So Dr. Borrero is the founding director of the Center of Innovative Research on Gender Health Equity, or Converge, and a tenured professor of medicine, clinical and translational science, and obstetrics and gynecology and reproductive sciences at the University of Pittsburgh School of Medicine. She is also the co-director of the Advanced Fellowship in Women's Health at the VA Pittsburgh Center for Health Equity Research and Promotion, or CHIRP. Dr. Borrero is a physician researcher whose work focuses on contraception and abortion care access, equity, and quality. Her research uses multiple methods and disciplinary approaches to understand the multi-level factors that influence reproductive health equity. Dr. Borrero has worked closely with scientific, government, and community organizations and agencies to help advance reproductive health sciences and policies to support all people's reproductive autonomy and their ability to build the families that they desire. We're so lucky to have her come speak to us this morning. So without further ado, we'd love to welcome her up.
Hey, good morning. Thanks for all of you for venturing out on this very cold morning. I'm really excited to be here. Thank you, Dr. Spears, for the invitation. So while I was preparing this talk, I realized that I actually gave grand rounds here about 6 years ago. And so for any of you that were there, I think some of the concepts that I'm going to be presenting today will sound familiar. But as the world has evolved and our understanding of equity and inclusivity have evolved, so too has our understanding of how to provide equitable sexual and reproductive health care. And so what I want to present today is an evolved yet dynamic vision for sexual and reproductive health equity for the nation. I have no relevant financial disclosures. So this is a brief outline of what I hope to present today. I'm going to first present a definition for sexual and reproductive health equity and talk about how this vision is a departure from our current approach. And then I want to spend a bit of time talking about the need for a new measurement ecosystem, both to help establish this nascent framework of SRHE, but also advance it and track its progress. And then I assume that many of you are clinicians, if not all of you. So I want to talk about how to advance or ensure SRHE in clinical practice. I want to say here that my lens is that of an internist, an adult provider. And I fully recognize that some of the principles that I'm going to be presenting may cause discomfort or, challenges that are unique to the pediatric population because of developmental considerations. And while I think I've had the great fortune of working with people in your department, such as Liz Miller and her other unbelievably brilliant colleagues across the nation to ensure that these broad principles are applicable in pediatric settings, I really welcome any feedback or pushback from you as we continue to evolve this nascent framework. And then I'll end with a brief call to action. So over the last few years, I've been part of a number of national work groups that are working to define this concept of sexual and reproductive health equity. And these work groups include broad and diverse stakeholders, people with both lived experience expertise as well as expertise by education. And what I'm presenting here is sort of an amalgam of some of these conversations and definitions that have been proposed. But SRHE reflects a state in which all people across the range of age, gender, race, ethnicity, and ability have what they need to attain their highest level of sexual and reproductive health, including self-determining and achieving their reproductive goals. So I'm going to spend quite a bit of time talking about this last phrase. First off, that's my area of expertise, but also because reproductive autonomy and self-determination are truly under proactive attack and highly vulnerable right now. So let me describe a couple of the key components that have been articulated as part of this SRHE framework. First off, it is a framework that recognizes the holistic interconnectedness of all aspects of sexual and reproductive health, including pregnancy avoidance, attainment, and termination, as well as having a safe and satisfying sex life. And we know that people experience many, if not all of these over the course, and healthcare needs with regard to all of these aspects across the course of their reproductive lives, and they shape and inform one another. It also recognizes that sexual and reproductive health is an integral component of overall health and well-being. It acknowledges the historical and contemporary reproductive harms that have impacted certain populations, and it seeks to at least begin to redress these harms by centering the needs of communities that have experienced these harms and continue to experience these harms, and therefore experience the greatest barriers to optimal sexual and reproductive health. And importantly, this is a system-level approach. It explicitly calls on systems, structures, and approaches to ensure SRHE, recognizing that interventions and programs that do not explicitly focus on equity often have the effect, even if unintended, of worsening or exacerbating inequities. As I was putting this slide together, I realized a couple of positive developments. The last time I was here, I spent a lot of time talking about specific concrete examples of reproductive abuses in our history. And I didn't feel that I needed to do that. And I could be wrong here, but I just feel like there's been so much greater attention and education in the medical community and medical discourse and education about this history. Suffice it to say, wherever you biopsy US history from the time of slavery until now, you will find policies and practices, both formal and informal, that have sought to control the reproduction of certain segments of the population in order to further societal goals. The second thing I realized is last time I went through a step-by-step rationale or argument for why equity is so important, and that it's a key component of quality healthcare and linked to empirical outcomes. And I think now we have reached near consensus, I hope, that equitable care for all people in accordance with their own values and goals is part of our ethical mandate as providers. In that vein, SRHE draws from foundational principles and frameworks that are increasingly valued in the healthcare system, including health equity, person or patient-centered care, and reproductive rights, justice, and autonomy. I want to spend a moment just talking about the sort of history of the reproductive rights framework. So it wasn't until the 1994 International Conference on Population Development that we saw a major shift in matters of reproduction. Up until that point, reproduction, especially in the global South, was thought to be a population matter that should be controlled by governments. And it was at the 1994 ICPD that there was unparalleled and near global consensus, minus China, that instead reproduction is a basic human right. And that started to enshrine this idea that family formation through childbearing, but other means as well, is core to the human experience and is meaning making. So this human rights framework was further expanded on and enriched by the reproductive justice movement, which was founded and articulated in 1994 by Black scholars and activists to call attention to the fact that, in fact, not all populations are able to realize these rights, these human rights, reproductive rights equally, and that a person's reproductive choices and self-determination are only as capacious as the resources that they have access to. The RJ movement also critiqued the reproductive rights movement in the US as very myopically focused on abortion rights. And it explicitly laid out a vision of equal rights and ability to not have children, to have children, and to parent one's children in safe and healthy environments. And so the SRHE framework draws heavily from the RJ movement. But I think there's key differences. Number one, I think once reproductive justice is fully realized, it will require an overhaul of many of our systems, not just the healthcare system, but housing, education, criminal justice. SRHE, in contrast, is applicable now, and it calls on systems that we are all part of to move towards a vision in which all people are able to realize their own reproductive goals and desires. So what's our current approach if it's not SRHE? And I think this is it. It's very siloed, right? So first silo might be maternal and child health. The second silo is family planning. The third, STI and HIV care. And practitioners, policymakers, researchers in these various silos rarely interact. Of course, this is not at all reflective of how people experience their sexual and reproductive health. And the harms of this siloed approach really manifest in a variety of ways, including fragmented care, in which people are unable to get their SRH care needs met in a timely way. Also, another harm is that policies and practices can often privilege one aspect of SRH without recognizing the expense of the other silos. For example, in the last 6 to 7 years, after the very high-profile ProPublica report on the state of maternal health and maternal morbidity disparities in the U.S., there has been much needed and overdue attention and investment in pregnancy-related health at institutional levels, at the state level, at the federal level. But there has been little to no discussion about the role of contraception and abortion in ensuring pregnancy-related health indicators. And so only after the Dobbs decision are we actually seeing and the harrowing news stories of pregnancy complications. Has there been more public discourse linking abortion care with pregnancy-related care? In contrast, the SRHE framework really proposes an integrated one that recognizes the inherent interconnectedness of all of these aspects of SRH and SRH care. So I'm going to turn my attention to the second silo, which I labeled family planning. And I'm going to argue that that field, which I am a part of, also needs a significant paradigm shift to achieve more alignment with the SRHE framework. So what is the current framework in the field of family planning? And the dominant framework, surprise, is that all pregnancies should be planned, right? So while the notion of planned pregnancy or Planned Parenthood first emerged in the early 20th century, when eugenics was actually a very prevailing ideology, it wasn't until the IOM released its report, The Best Intentions, in 1995, that Planned Parenthood or planned pregnancy was articulated as a US public health goal. And in that report, the committee said that they urged the nation to adopt a new social norm, that all pregnancies should be intended. That is, they should be consciously and clearly desired at the time of conception. So the corollary, of course, is that unintended pregnancy is a problem, and it's a universally negative event. To that end, reducing the rate of unintended pregnancy and the rate of teen pregnancy have been included on every iteration of Healthy People 2020. Have been included on every iteration of Healthy People from 2000 to 2030. So in that sense, the unintended pregnancy framework has really become, a central tenet of SRH healthcare delivery, research, and public policy. The government began to conduct population-based surveys to track estimates of unintended pregnancy and teen pregnancy. And that research began to link unintended pregnancy with a range of adverse social and health outcomes. And I will say for the first 5 years of my career, all of my grants started with these sentences, right, as the justification for why we need contraceptive care delivery. So unintended pregnancy in these studies has been linked to inadequate or delayed entry into prenatal care, higher prevalence, smoking and alcohol use, higher likelihood of depression and IPV, lower likelihood of breastfeeding, and higher incidence of poor perinatal outcomes. However, as we began to critique these studies more, we realized that the studies assessing the relationship between unintended pregnancy and adverse outcomes are complicated by numerous measurement and analytical issues. The foremost being you can't randomize someone to an unintended pregnancy or not. And so the circumstances and confounding variables that give rise to unintended pregnancy are often the same that give rise to poorer perinatal outcomes. And therefore, these studies really cannot establish either causality or directionality. Similarly, teen pregnancy prevention sort of rested on this notion and studies that linked teen pregnancy with increased reliance on social services, poverty and welfare reliance, poor educational outcomes, and really cast teen pregnancy as a public health issue. I feel like Savannah was right behind me. Very similarly to the data on unintended pregnancy, scholars have re-examined the data, including economists, and have concluded that early childbearing is a symptom of economic disadvantage rather than the cause. And this is really important because the public health approaches are different. We need to change the opportunity structure rather than simply and solely promoting contraception as a solution. And I want to share this, this excerpt from Melissa Kearney's paper. This is very economic ease, but I think it just gives you an indicator of sort of their read on the totality of the evidence, which led them to conclude that being on a low economic trajectory in life leads many teenage girls to have children. Surprisingly, teen birth itself does not appear to have much direct economic consequence. Instead, it reflects a decision among a set of girls to drop out of the economic mainstream. They choose non-marital motherhood at a young age instead of investing in their own economic progress because they feel that they have little chance of advancement. What about health outcomes? So again, just like unintended pregnancy, it's really difficult to tease out confounders and determine whether young age per se is causally related to poor medical and obstetrical outcomes. The data, of course, are strongest for those who are less than 15, but these pregnancies are very rare and often or mostly the result of non-consensual or forced sex. There is research by Arlene Geronimus and supported by others that propose that early childbearing in some populations, namely low-income populations of color, is in fact potentially protective, given that exposure to toxic stress, cumulative toxic stress, and racial inequality and other structural and social inequality ages people with pregnancy capacity in those populations at a much faster rate. This is a term Arlene Geronimus has called weathering. And it diminishes people's pregnancy capital or maternal capital at a much younger age compared to more privileged populations. So how have these public approaches shaped our clinical approach? The focus on reducing unintended pregnancy and reducing teen pregnancy have very much filtered into how we interact with patients one-on-one. So first off, unintended pregnancy and teen pregnancy in addition to being a public health problem, are viewed as universally negative, or are viewed as being perceived by the people that have them as universally negative events. And this really, this perception really fueled the enthusiasm for LARC methods. So long-acting reversible contraception includes IUDs and implants. And when these methods came out in the early 2000s, we saw a great deal of fervor in the medical community as a solution to the problem, the public health problem of unintended pregnancy. And you may remember that AAP even, along with other medical organizations, recommended IUDs and implants as the best birth control or first-line options for teen girls. They have since recanted that, but this, I think, was around the, let's see, what does it say, 2014. So not so long ago. In addition, we began to see the rise of clinical performance metrics that were focused on provision of these long-acting methods. So for those of you who are not familiar with NQF, this is the National Quality Forum, and it's been under contract with the US federal government since about 2000 to convene a consensus body to recommend measures specific for specific federal programs to advance quality care. Moving forward, the CMS has now awarded this contract to Battelle, so you may not hear about NQF. But this is the portfolio of reproductive health measures. It's just chlamydia screening, and then there are 3 contraceptive care performance metrics all around provision of moderately and highly effective methods. There are some other NQF endorsed measures from maternal health and pregnancy-related health, but this is all we have for sexual and reproductive health. So out of all of this zeal for LARC came a lot of clinical counseling approaches, funding, programs to promote widespread use of LARC. And with it, serious concerns from the health equity and the reproductive justice community about the potential for reinvigorating coercive practices around contraception. At the same time, a lot of qualitative work began to emerge that showed a fundamental mismatch between our approach, our unintended pregnancy reduction approach, and people's experiences related to pregnancy and pregnancy planning. So in one of our studies, we really, and again, this is reiterated in multiple other qualitative studies, but many people do not have clear or binary pregnancy intentions. So this is a quote from one of our studies that we conducted probably around 2011 with low-income women in Pittsburgh. And one of our participants said, well, like, you never had it in your mind that you wanted to get pregnant. It just happened. We heard this over and over and over, that pregnancy just happened. And what the women in our studies told us that they subsequently determined whether or not these pregnancies were acceptable after they learned of the news, and based on an internal assessment of their sort of individual and social capital at the time. Importantly, people may not necessarily see pregnancy planning as desirable or achievable. And people told us, because of ambivalent feelings around pregnancy, that is, you know, I would love to have a baby right now, but this is not a good time for a variety of reasons. This ambivalence often led people to feel that IUDs and implants are often too good. So this is a quote from Jenny Higgins' study with college-age participants. And one of the participants said, and I think I shared this last time because I love this quote, IUDs and implants really take away the element of surprise of having babies, which some people want and some people really, really don't want. You can accidentally forget the pill and get pregnant, but an IUD is not going to pop out and take a jog around the block. Oops. Sorry, give me a sec. Okay, so this concept of pregnancy planning not being achievable was also something that became very evident in our work. We asked people, what does it mean to plan a pregnancy? And these are all, remember, in our study, low-income people. They still held sacrosanct the idea of socially normative planning. That is, you should have your finances in order, you should be in a stable union. At the same time, they recognized that a lot of these things were elusive. And so it seemed to them that it was socially more acceptable to have an oops baby than to plan one in these non-normative circumstances. And this was really reminiscent of Catherine Eden's work in her landmark ethnography, Promises I Can Keep. And I just want to share a line or two from that ethnography. So she said, the lack of a clear plan does not mean there is no desire to get pregnant. Yet those who admit, even to themselves, that they're trying to have a baby invite public contempt and self-reproach, for they know that the choice to bear children while young and unmarried is in many ways absurd. At the same time, they wonder if their circumstance will ever be right. And then finally, I think we all know, either from personal experience or otherwise, that unintended pregnancies can be happy, welcome events. They may be catastrophic for some, but they may actually signal a change towards a more positive trajectory in some people's lives. This is a quote from Abigail Aiken's study in Texas. One of the participants said, honestly, although she wasn't at all planned, I think my baby girl saved me when I think what I would be doing now if she never came along. So if there are populations of people whose social and structural realities and even their personal orientations do not support the idea of a consciously desired and planned pregnancy, and who are often happy when confronted with what we would label an unintended pregnancy, what are we trying to accomplish? Especially knowing that the evidence linking unintended pregnancy and teen pregnancy is quite weak. Linking these with adverse outcomes is quite weak. So I would suggest that we need new measures. Measures can catalyze cultural and structural change, just like it did with the unintended pregnancy framework. Moreover, SRHE, as I said, is a system level approach, and we build systems around our measured goals. So what gets measured gets improved. So there's a call for a new ecosystem of measurement that will really advance the work of SRHE. Our current public health and clinical performance metrics fall short in that they are inconsistent with our evolving values and what people want and need in their SRH care. At worst, these frameworks, the reducing unintended pregnancy and reducing teen pregnancy framework, cause harm. For one, by perpetuating sort of shaming and blaming narratives around people's non-normative pregnancies. And this can alienate people from healthcare, the healthcare system, and rob them of the opportunity to get the type of care that they need in a dignified and respectful way. So a new measurement system, as I said, I think can catalyze cultural and structural change. It can operationalize the principles of SRHE and then measure progress towards them. So I'm going to talk a little bit now about some new and emerging measures. They're all focused on sort of the family planning, but keep in mind there are some really innovative value-based measures for pregnancy-related care that are also in development and being implemented now. So first I want to talk about self-assessed pregnancy acceptability, SAPA, which is some work that our team here at Pitt is conducting. It's an NIH grant with all of these wonderful collaborators across the country. We've been engaged in this work for the last 3 years. And so I'm excited to present our framework and measure for self-assessed pregnancy acceptability. So just to recap, unintended pregnancy is a limited measure, right? It doesn't reflect the diversity of pregnancy experiences or even desired pregnancy experiences, particularly for marginalized communities. It's only weakly correlated with public health outcomes, but yet it is often used as a proxy for these longer term outcomes that can't be measured. Because it is focused on pregnancy intention, it provides information really only about contraceptive need. So it hinders our ability to predict and respond to broader pregnancy-related healthcare and social needs, particularly the need for abortion care and parenting support beyond the limited focus on contraceptive efforts. Taken all together, unintended pregnancy is an insufficient measure of reproductive autonomy and also the degree to which our efforts in the US support people's needs around family formation. And so our team felt that we really need a new person-centered measure that more fully captures the complex cognitive, affective, and circumstantial factors that influence pregnancy and reproductive outcomes. So this is just a, I know this is a lot, but what I want to highlight here is this is what the measure actually looks like. And in this slide, I just want to acknowledge that you'll see these arrows on the side that acknowledge the macro level factors, including the various manifestations of social and structural opportunity and oppression, as well as on the right side, the micro level factors, including people's own unique social, relational, medical contexts that influence the middle box, which is perceived reproductive autonomy. And in that sits our actual measure of SAPA, self-assessed pregnancy acceptability. And I'm going to go through the components because I think it is really paradigm shifting. Before I get there, I just want to give a note about how we developed this measure. So we conducted in-depth interviews with people who had recently confirmed pregnancy and then followed up with them. We engaged in a robust stakeholder engagement process with, again, experts via education as well as experience, including your own Youth Research Advisory Board. And now we are starting the process of validation testing with longitudinal surveys with 500 people. Okay, so here is the model. Again, the part in the blue, the light blue, is our actual measure. But note that SAPA is both a component of and shaped by perceived reproductive autonomy. So what's a critical difference between this and unintended pregnancy measures are a lot of things, but the first one I want to point out is that this is anchored after a person learns that they are pregnant or confirms a pregnancy, as opposed to assessing what their pre-pregnancy intentions were. And in our model, you can see that there are 3 possible pathways through pregnancy: one for parenting, one for abortion, and one for adoption. Each path has 2 domains. The x-axis depicts people's attitudes about that option, and the y-axis is the feasibility of that option. So the measure itself consists of 11 items, which are used to determine people's ratings across these 3 matrices. And in addition, a question here about whether they preferred to have avoided getting pregnant in the first place. And their answers to this question will categorize their pregnancy situation as either highly acceptable, unacceptable, or mixed acceptability. And I'm going to go give you an example of how this all works. Before I do that, I just want to sort of highlight that, again, SAPA accounts for 3 possible pathways through pregnancy: parenting, abortion, and adoption. And I want to just call out that the YRAB encouraged us to add surrender as an option to pregnancy. And that was, a really insightful addition that we had not thought of. But surrender means giving up the child to either a safe haven or a church or a fire station. And that felt much more accessible for adolescents than a formal adoption process. So I think one really notable difference about this new measure is that it assesses the acceptability of the entire pregnancy situation, not simply the acceptability of parenting. So as an example, this is the one of the most utilized measures of unintended pregnancy. It's a single item as opposed to ours, which really captures a multidimensional approach to understanding pregnancy experiences. This is a single item that focuses on timing pre-pregnancy. And you can see here that they really conflate pregnancy with parenting, right? So thinking back to just before you got pregnant with your new baby, how did you feel about becoming pregnant? And in that is the assumption that pregnancy must lead to parenting. So our measure is quite different in that it accommodates other pathways. So before I get into examples, just again, a little bit of orientation. Each pregnancy pathway has two dimensions, attitudes and feasibility. And the pathway, each pathway is either open or closed based on people's answers to the 11 questions. Pathway is closed if either their attitudes or feasibility are low. Conversely, the pathway is open if both attitudes and feasibility are high, and then the pathway is mixed in all other scenarios. So let me give you an example of an unintended yet highly acceptable pregnancy. So this is one of our participants from California. And she said, initially I was freaked out. And then after talking with my partner about it, I felt it shift very quickly. Then I felt just really excited and happy. And it's been like that ever since. I actually feel like it wasn't something that I planned, but it's somehow a perfect time the way that it happened. So again, this is an unintended pregnancy that would have been characterized as a universally negative event, yet is highly acceptable for this participant. This is an example of unacceptable pregnancy. So this is one of our 23-year-old participants in Texas, and this is post-obs. She explained that she had wished she had never gotten pregnant, that she cannot be a parent, that the pregnancy was poorly timed and a baby would not be well supported. However, she's against abortion, but he wouldn't be able to get one even if she wanted to because she lived in Texas and she did not consider adoption as an option for her. So this is sort of her matrix. And you can see that this is, an unacceptable pregnancy because she has no option for either parenting or abortion. And importantly, in the post-obs climate, even if someone were to have positive attitudes towards abortion but couldn't access it, that would lead to an unacceptable pregnancy. We did follow up with this patient or this person, and she ended up having a miscarriage, but was in a situation in which she felt that she had no viable options. So this new self-assessed pregnancy acceptability measure, I think, in and of itself is really important and paradigm shifting and very different from the unintended pregnancy frame because number one, it's person-centered in that it allows people to assess the acceptability of their own situation rather than relying on what I would call a flawed or problematic planning framework in which we determine whether or not this is an acceptable situation. It considers abortion and adoption in addition to parenting as viable options, and it accounts for feasibility of each pregnancy pathway based on one's social and structural and sort of broader political climate. We also, however, hypothesize that supporting people to realize their goals around pregnancy and reproduction should lead to improved social and health outcomes, and that our improved measure should better correlate with outcomes more strongly than the existing unintended pregnancy measures. And so we've listed, you can see here, some of the hypothesized outcomes, including the pregnancy outcome itself, whether it ends in miscarriage, abortion, or live birth, but also perinatal outcomes. And then perhaps most importantly, this new measure really helps us discern clear and comprehensive policy implications that are not solely focused on contraception. For example, we'll be able to say what % of pregnancies are unacceptable solely because the pregnant person does not have adequate financial support or resources to parent when they want to. Or conversely, what % of pregnancies in the US are unacceptable because abortion is not available. So our goal for this, and again, we're right in the beginning stages of validation, but our long-term goal for this is to embed the measure in epidemiological surveys such as the NSFG or PRAMS that currently assess unintended pregnancy. So this would be either a replacement or supplement. And we can imagine that we would replace things like the Healthy People 2030, or actually every iteration of Healthy People objective, from reducing the proportion of unintended pregnancies to reducing the proportion of pregnancies that are unacceptable to the people who have them. I also want to just give a shout out to this other new and emerging measure that is on the horizon. So SAPA really focuses on people who've had pregnancies. This is a much broader overarching vision for sexual and reproductive well-being. And I think, I know in this department, well-being has been much discussed, but it is increasingly recognized even across governments and policymakers as a desirable outcome, even perhaps supplementing GDP as a measure that we should both measure, as a metric that we should both measure and prioritize. And so right now, SRWB is defined as a state of complete physical, mental, and social fulfillment in all matters related to sex and reproduction. And it currently is conceptualizing these domains, which include the freedom and ability to control, act on, or not act on one's own sexual and reproductive decisions. So those are population metrics that are, we hope, emerging and will ultimately be embedded in US surveillance systems to track our progress towards meeting people's needs with regard to family formation. We also have clinical performance metrics, and these you may all be more familiar with, HEDIS measures or NQF measures. These are quantitative measures used to assess indicators of high quality care. They can include processes, outcomes, increasingly patient perceptions, resource utilization, and or care coordination. And they can really help to identify disparities in areas of improvement and therefore drive continuous performance improvement efforts. And importantly, they promote transparency and accountability among your stakeholders and community members. So as I mentioned before, we currently have a couple of claims-based contraceptive care performance metrics that have been endorsed by NQF. Just going to highlight the top two here, which are, and these, I tried to find out if they're being used here, and we don't believe they are, but state Medicaid programs often require this. So I suspect that that this is being reported back to Pennsylvania state program on behalf of MA programs. So the first two are contraceptive care measures that are focused on moderately and most effective methods. And then the bottom two are basically the repeat for people who are postpartum. So ensuring that all of these people have access or get to, are able to access LARC and prescription methods. However, as I mentioned, there's concern about fueling coercion. Even though OPA, this is the Office of Population Affairs, is the steward of these measures, and they have issued a gray box warning saying these should not be used as target benchmarks. Instead, think of them as floor metrics. That is, if you're noting that, for example, only 1% of your patient population is getting a LARC, that's what should be causing concern. However, that is not how people interpret or implement performance metrics. And so it's always, the tendency is the more, the better. And of course, this can fuel coercion. And so one of the approaches to help serve as a balancing measure, it's been developed by my colleague, Christine Dellendorf at UCSF, and it's the PCCC. It assesses the quality of person-centered contraceptive counseling. It has 4 items, querying about feeling respected as a person, being allowed to say what mattered, taking preferences seriously, and giving enough information. And the National Quality, NQF, not NSF, endorsed the PCCC in 2020, again, as a balancing measure. This has not really been implemented widely yet, but it is meant to be used in tandem with the OPA contraceptive care measure to help ensure that while we are measuring access to these methods, that we're not doing so in a coercive manner. PCCC has also been incorporated into surveillance surveys to track the status of contraceptive counseling quality in the US. And importantly, it can assess the extent to which people's needs, particularly people of color and others who've experienced reproductive inequities, are met in clinical settings. So trying to sort of lift the PCCC as an important measure to include. Okay, so what does SRHE look like in clinical practice? And I don't know if any of you are familiar with the QFP. Certainly those who work in Title X settings must be. But these are clinical guidelines that were issued by OPA, the Office of Population Affairs, and CDC in 2014. And I was fortunate enough last year to work at HHS and OPA for a year, serving as the clinical, scientific, and medical advisor. And one of my goals was to overhaul and update the QFP. So it was really outdated. But we are in the process of updating it, and we hope that it will be coming out in fall of 2024. And a couple of key differences. First, it is guided by a vision of SRHE. Second, our anticipated audience is far broader than just Title X clinics. We want anyone who's touching sexual and reproductive health care, or patients who might have sexual and reproductive health care needs, to use this or consider this for best practices. So this includes PCPs as well as specialists. And I want to say, like, huge shout out to Tracy Kazmersky, who has taught me, and her formidable cadre of mentees, including Colleen Matthews and Laura Kirkpatrick, taught me over the years that specialty medicine, especially for people with serious chronic illness, is a really important but overlooked setting in which to query about people's SRH needs and get them to the right place. And so we want the new QFP to be to accommodate all of that. And I think it's a little bit gutsy for me to show you what the topical domains are, because it's not gone through clearance, but we're going to be touching on a broad range of sexual and reproductive health care for people, again, of reproductive age, except for pregnancy-related care. Notably, we are hoping to incorporate abortion provision and gender-affirming care. Again, this hasn't gone through clearance, so don't hold me to it. All right, I am going to end with a couple of general principles. I think a key thing to understand is that SRHE looks very different in different settings, and providers and institutions will actually need to do the hard work of introspection and critical analysis to understand how to apply these principles into their settings. Sadly, there's no equity checklist. So I'm going to offer tools that are broad enough for you to think about. So acknowledging historical and ongoing harms related to SRH care in your institution. And these are, I think what I'm presenting here is sort of what is your role in pushing or your institution to have more cultural rigor and adopt an SRHE framework. And this requires engaging in institutional self-reflection. I want to share a really, I think, inspiring story. So a couple of years ago, one of our fellows, family planning fellows, Kavitha Vinikar, wrote this perspective piece in the New England Journal of Medicine, really calling out segregation of care in McGee Hospital. And there it's quite pronounced because publicly and privately insured clinics are completely separated and by literally a fork in the hallway. And even worse, the publicly funded and insured clinics are referred to as, the tan, yellow, pink, and in aggregate, the colored clinics. And so because of this single perspective piece, McGee clinics are overhauling their entire clinical pathway as of this month to integrate their clinics. So, just again, a call out to some of our trainees and junior folks. I think fresh eyes to processes and practices that many of us have become inured to are exactly what's called for here. Offering the full scope of SRH care, including through streamlined referrals. And we wrote a piece really calling out the medical community's complicity in marginalizing abortion care. So this in particular, abortion care has been sidelined. So making sure that we have sort of wraparound full scope services is really critical, ensuring SRHE, because we know who falls through the cracks. Integrating a trauma-informed approach into organizational culture, recognizing that our clinical spaces are not always physically or psychologically safe for everyone. And so really doing the work to figure out, including collaborating with community members and patients, expanding access to services outside of physical clinic spaces through telemedicine, and you have a mobile van. So innovative service deliveries for whom this does not feel like a safe space, hiring and supporting a diverse workforce. And then finally, understanding the parameters and unintended harms of state mandated reporting systems. I have less experience with this than probably all of you, but I just want to call attention to Dr. Jamila Parrott's excellent New England Journal piece, and really calling out the our collusion with the carceral system. There has been a significant rise in pregnancy criminalization since Dobbs especially, and the medical system is usually the pathway into entry for the carceral system. So sort of think about your role in helping your institution think about policies that minimize the harms. And then at the individual level, again, engaging in individual self-reflection. This requires a lot of introspection to understand one's own biases and assumptions, and actively work to appreciate how they show up and impact clinical encounters and recommendations. I know that you all probably strive and probably do provide person-centered care beautifully, but I think, as we're exposed to more diverse perspectives that challenge our latent biases, we only grow in our capacity to provide patient-centered care. So I'm hoping today I presented some concepts that might lead you to reflect on how you might continue to grow in this capacity. I would say that these are very broad principles, but are especially important for SRH care because it is such an intimate part of people's lives, and because sexual and reproductive health services have been weaponized. So establishing and maintaining rapport is of critical importance with SRH, and matches with how people want to receive their care. Assessing people's preferences for both decision-making as well as the information and services they wish to receive. And then providing tailored information and confirming understanding. Ensuring confidentiality, especially in the pediatric population, is of critical importance. And then learning about and educating your patients about self-care options, which again, we want to help maximize people's ability to receive the care they want, both inside and outside of the formal healthcare system. And these options are growing. The QFP will provide a lot more concrete suggestions for how to accomplish all of these things, but this is, again, just broad principles. I'm going to just give you some examples. Again, QFP will go through more concrete scripts and things like that that can really help ensure that you are embodying SRHE principles, but just as something to take home. I think often in pediatric settings, especially with adolescents, there's a tendency to assume people do not want to get pregnant and ask them things like, what are you using for contraception once you assess their sort of their sexual history. And instead, I would urge you to be open to the possibility that people do not have the same reproductive goals that you might have had or that you think they should have. And so more open-ended questions such as, can I help you with any reproductive health services today? We use the PATH questions in clinics. Do you think you'd like to have more children at some point? Have you thought about when? How important is it to you to avoid pregnancy, which helps to get at ambivalence? And I think Liz Miller uses some derivative of that, like how does pregnancy fit or not fit into your life? Okay, and last slide, I just want to encourage you to own this. So as I said, I went to the government last year, and when I went, I came with this vision and a blueprint for how we get this country to sexual and reproductive health equity over the next 15 to 20 years. And I learned well, first of all, they laughed in my face because the government is in fact not a place that can hold a long-term vision, right? They think only in four-year increments. And with SRH, which is so incredibly highly politicized, anything we did was very likely to either not grow or be dismantled by a hostile administration. And so as that began to sink in, that the government would not be able to actually save us and reverse this calamity that we're finding ourselves in post-Dobbs, it increasingly dawned on me that it's truly up to the collective we to bring about cultural and structural change. And I actually left the government early because I felt this renewed sense of purpose and clarity. I think it takes all of us in our respective roles as researchers, clinicians, patients, administrators, advocates to advance SRHE. It is not a niche area, right? All of us have had, will have, continue to have SRH needs, as do all of our patients. And so it's going to be us holding our systems accountable. I did learn that the government, while not proactive, is quite reactive, as are other institutions. So it is, again, it's up to the collective us to push these systems and structures to the future that we want to see. Okay. I know I left zero time for questions. I'm sorry. Happy to stay longer.